Good evening, our dear audience. My name is Rania Al-Aisawi. I'm Professor of Ophthalmology and Consultant Pediatric Oculoplastics and Strabismus Surgeon at Cairo University Pediatric Ophthalmology Department. I would like to welcome you all attending our Pediatric Oculoplastic Surgery webinar hosted by the Cairo University Pediatric Ophthalmology Unit in collaboration with the Memorial Institute Kids Eye Hospital and sponsored by FCI International Pioneers Group. We are thankful for their continuous support to all our events. Our meeting today is organized by RM Events, whom again we thank for their continuous technical support at CUPS and is proudly recognized by the Egyptian Medical Syndicate. I am pleased to co-moderate this meeting with my dear friend, brother, and colleague, Assistant Professor Dr. Sameh Hassan from Cairo University, and dear Dr. Heba Mitwalli from the Memorial Institute for Ophthalmic Research. We are so much honored to have with us today Professor Dr. Christoph Hintschich. Professor Dr. Christoph Hintschich is the head of the Oculoplastic and Orbital Service at the Munich University Eye Hospital. He graduated in ophthalmology in 1991 after receiving short internships in tropical medicine and anesthesiology. He was a fellow to eminent oculoplastic surgeons in Munich, London, and Amsterdam. He is a member of the German Ophthalmology Society and the head of its section of oculoplastic and reconstructive surgery. He is also a member and former secretary of the ESOPRS from 2006 to 2014. Dr. Hintschich is the author and co-author of a number of articles published in leading ophthalmic journals and a member of the editorial board of several journals. His main professional interests are functional and aesthetic eyelid surgery and orbital surgery, in particular surgical rehabilitation in Graves' disease and anophthalmic socket management. On behalf of all my colleagues, I would like to welcome Dr. Hintschich and thank him for being with us today. We have a lot of distinguished speakers today, but first I leave my dear Professor Dr. Hani Hamza to welcome you all. Dr. Hani Hamza is a Professor of Ophthalmology at Cairo University, Vice President of the Egyptian Vitreoretinal Society. He is a great expert in the management of retinopathy of prematurity, and he is the current Director of the Pediatric Eye Unit of Cairo University. Hello, Dr. Hani.
Hello, Dr. Rania, and good evening, everyone. On behalf of the Cairo University Pediatric Ophthalmology Unit, I would like to welcome you all to this meeting. And I would like to thank Professor Rania Al-Aisawi for the initiative and the great enthusiasm for making this meeting possible. I would like also to thank Dr. Heba Mitwalli from the Memorial Institute of Ophthalmology for their participation in this meeting and contribution. And also Dr. Christoph Hintschich, our international guest speaker. It's our pleasure to have you with us. Although I'm a vitreoretinal surgeon, but I was always impressed with my oculoplastic surgeon colleagues who always did a great job in doing reconstruction for patients, and maybe the end-stage vitreoretinal surgery would land at the oculoplastic at the end. So thank you very much, and now I leave the floor to Professor Rania Al-Aisawi to start the meeting.
Thank you, Dr. Hani. So, Dr. Hintschich, please share your screen, please.
So first, good afternoon. Thank you very much for inviting me for your webinar. The Cairo University, and particularly Professor, of course, Al-Aisawi. And the topic I was given to talk on, let me see with that. Yes, this is dermal fat graft for pediatric ophthalmic socket reconstruction. Of course, this is not a new topic, but I try to put together some of the central points positions. We are talking about the dermis fat graft, so talking about here a graft consisting of dermis without the epidermis and adjacent fat tissue. And we are talking about sockets, and this is what you find in the dictionary. The socket in ophthalmology does mean an empty orbit without an eyeball, so an anophthalmic socket. The whole reason why we are talking about this procedure is to avoid more or less the sequelae of enucleation seen on this picture here. Volume deficit and structural changes nicely seen also on that CT scan of this patient. And this leads, and this is what you all know, that term of a post-inoculation socket syndrome called PES, which was defined by Tyers and Collin. And we are not going into detail of this, just in order to show what is the background of all. In order to prevent this, and this is also not new, ophthalmologists have put in orbital implants into the socket, and this for more than 100 years, in order to do volume replacement and to restitute the orbital architecture. And in principles, you can do that primarily directly after enucleation or later on as a secondary implant. And of course, there are many, many different alloplastic implants which have been used and described. And there is autologous graft, and this is the dermal fat graft, which we are talking about. This, as I told you, is not new. It goes back to Barakat more than 100 years ago, starting with fat and then with dermal fat grafting. It was kind of resurrected by Byron Smith in the 70s in the United States, and it came actually over to Munich, and with that actually over to Germany with Charles Bayer-Macula, who was my first mentor, and he brought me into ophthalmic plastic surgery. That was in the 90s, beginning of 90s. So this is the picture you all know. We're talking about tissue taken from this area in the buttock, deepithelializing, and then transferring it into the socket. There are some specific advantages of dermal fat graft, and it combines actually a volume replacement, a kind of restitution of the orbital architecture. So you suture your muscles at the edge of that cone, which kind of camouflage the original situation. And what is very nice, you are gaining some conjunctival lining with the healing. So you are kind of increasing the surface of the socket. So the procedure, only for those who have not seen it yet, I showed that before also in Cairo. This is an aspect usually you are not used in an ophthalmic theater. However, this is the place where we take the graft. There is an imaginary line from the anterior superior iliac spine to the ischiatic tuberosity, and about half of it superior 4 to 5 centimeters. This is about the area where we very safe can take that graft. It's usually a diameter of 25 millimeters in adults. It might be a bit smaller. Usually it is smaller with children down to about 19, 20 millimeters. And you kind of blow it up with an injection of saline in order to get an easier epithelization, as you can see here with a large blade. And once you've done that, you severe that through the dermis and kind of explant the whole dermis. And you can see nicely here, this is the dermis and this is the adjacent fatty tissue. And this is then transferred into the socket either as a primary or as a secondary implant. Of course, you can also put a graft into the sulcus. I'm not going to focus on this with that time, but in the majority of cases are put into the socket. You suture it first to the muscles in the primary procedure, to the underlying tissue, and close the conjunctiva. Put in a shell, and this is the healing phase, and this is the healed socket then. There are, I put together some tips for clinicians. Be careful while position the patient to avoid damage to joints. You do that together with the anesthetist while you prepare the patient for the removal of the graft. You ablate the epidermis layer completely, otherwise there's a risk of the smelly socket later. Use strong suture materials in order to have that really properly closed. Do not, and that's quite essential, do not squeeze the graft under pressure into the socket. Only what goes into it very lightly. Otherwise, you can trim it before because the vascularization is impaired if there's too much pressure. And always use a conformer shell postoperatively. And of course, what else is essential? The ocularist. He has to produce the best possible artificial eye, and it is quite essential to have a good cooperation to get known with your ocularist. And we in Germany, we do use, or they use, the glass artificial eyes. Now here we see a girl, age 5, with a painful blind eye, and this is her then after the enucleation with the dermal fat graft and with her eye glass artificial eye. This is her socket showing the anterior surface, which is a flat surface, which is nice to fit a proper artificial eye. Another pediatric patient is in here, the big drummer before the enucleation. And you see him here 2 years after the enucleation. And there's always a question, does that fat stay? Yes, and it is our experience and also of others, it does stay. And that can be shown here, the chap after 3 years. And then you see him here after 8 years when he's age 10. With quite a reasonable, uneventful aspect. And this is socket showing the anterior surface of the graft. Another young patient, he's not a young child, but he is quite a chap, and he has that physical eye before enucleation, and you see him here 6 years after enucleation. And you say that stays stable, and this is in 10 years after enucleation, when he's a grown-up chap. And the last example here, he was not a real child, he was an adolescent, and you all know these kind of post-traumatic ophthalmic eyes, they are cosmetically quite difficult, because whatever ball you put in, they tend to be under volumized. So there's often a loss of volume, and you can put in that graft here, and this is in here 3 years afterwards. And I show this because I have here of this patient the CT scan and the reconstruction. And you nicely see actually how much volume is replaced by that dermal fat graft. And you see the regular muscle cone in that chap. And we saw him 15 years later. He hadn't had a new prosthesis for 5 years, but the volume was still there. You can use that graft in difficult situations. This was a Polish chap. He came for removal of an ocular kind of orbital tumor. And if you see that CT scan, of course, you might already guess what it is. If you go to another layer, you find that tiny eye, of course, obviously with a big cyst. And we can unfortunately not go into details. There are different ways to deal with that. Usually you can just remove the cyst. But you see also what the cyst did, a huge bony orbit. And what we did then, we did remove that cyst and that tiny microphthalmic eye, and we put in a dermal fat graft. And additionally, you can put a baseball implant. And I think it did a rather reasonable job to replace that huge volume. Now I just want to point out a very, luckily a very rare condition, but it is a well-known condition, which is the congenital anophthalmos. And everybody who's dealing with congenital anophthalmos knows it is a very difficult problem because you unfortunately never will get it right. It is something we have to tell the patients, but what I think what we should try to get these children be able to wear proper prosthesis. There will always be asymmetry. They are born with that asymmetric bony orbital condition. And you can start with prefabricated conformers here. You can do molded conformers. However, it is not ideal either. So there was the question, or is still the question, is the dermal fat graft good as an orbital expander? I don't think, and most probably not, but I think it is very suitable for these patients. Why? Because you can fill the orbit, and I'll show you where. You can deepen the fornices, and with this, you get a better prosthesis fitting. So this tiny drawing here, and whoever has seen these patients, they have tiny little small sockets. Often they have these little V-shaped condition. They had often some round conformers, and they turn and tilt. It is difficult actually. If you put in such dermal fat graft, you kind of increase the depth of that fornix, and you fill up that space here, and you get a flat surface in order to put in a kind of regular artificial eye. And this example here of that child after still when she was young, with that socket with nice fornices, and this is when she's getting older, 6 years later, 12 years later. And of course, it is not symmetric, it's not ideal, but I think it is really helpful. Now, of course, very shortly, there is no procedure without possible complications. This is something like granuloma formation, hair growth, inclusion cyst formation. The worst complication is a necrosis with a loss actually of the volume, then leading to post-innovation socket syndrome. Now, this is what is this chap? This is a chap with an orbital tumor. No, it is another sequelae, or we can call it a complication, of course. It is not very common, but it is well described in these patients. You can see here, this is his anophthalmic socket, and you see a proper dermal fat graft. And this is so proper because it grew. It grew both with his age, but also, you see, he was a tiny little chap when you put it in, and he was quite a proper chap, over 95 kilos when we saw him with that. So they can grow. Very shortly, beside the primary, we are dealing with secondary implants. These problem of exposed extruded alloplastic implant, they can occur in children. They do occur in children. And I think the best way to deal with before starting fiddling around complete implant removal and a secondary dermal fat graft, as done in this chap here. And you see him here with the artificial eye, with that healed socket, and you see him here 7 years after surgery. And again, you have to think about which side was it actually. So he is still quite symmetric. There was a fellow of mine from Italy many years ago. She looked after these patients, after children. That were 12 pediatric patients then, 2 with congenital anophthalmos, and 8 of them were kind of judged as good results with good fitting of the prosthesis, complications, hair growth, a central graft ulcer that was repaired, and 2 growing implants, which can be managed surgically. In conclusions, Dr. Tarantini thought it is a safe and quite advantageous procedure for young patients. And this was not the only publication. There was one from 2001, pediatric primary enucleations, promising implant for the pediatric and ophthalmic socket. He was concentrating on patients after implant exposure, so the secondary implants, and the procedure can be particularly advantageous for pediatric post-enucleation patients, was his conclusion. Even Italian Ferrantaleoni now very recently found satisfactory orbital volume along with that procedure. And I put together 2 more publications. One, unilateral dermal fat implantation in pediatric orbit. And this kind of publication is aiming at the question whether that helps stimulate orbital growth in patients who had been enucleated in childhood. And I come to that very shortly later. And this publication treated with enucleation and primary dermal fat graft. They did not find statistically significant difference in bony orbital volume. Now, keep that in mind when we come to the last part of that presentation. First, of course, this is, I think, is quite good statement. Generally, the management of an anophthalmic socket in a child younger than 5 years requires an implant that can increase the size, such as a dermal fat graft or tissue expander. So in summary, for the indications, enucleation at any age, and particularly preferable in pediatric population. For difficult conditions, we've seen that this is very rare, and of course, for congenital anophthalmos. Now, this other, do I have the time? I think I have another 2 minutes. Parents and pediatricians asked, do we have to expect facial asymmetry requiring any procedures after early enucleation? So, does early enucleation cause bony orbital maldevelopment, and does that cause facial malformation and asymmetry? And there was one statement, and that goes 50 years back. Among the parent chosen in ophthalmology, there's one at least which requires close scrutiny. This is the belief that orbital growth is checked following enucleation in childhood, resulting in more or less maldevelopment and facial asymmetry depending upon the age at which enucleation was performed. And this was then one of the questions, and this goes back to my PhD, which I did with Leo Konev in Amsterdam, where we did orbital scans, interactive segmentations, and 3D reconstructions with volumetry. And there was a group of anophthalmic patients, one group young, age enucleated, others adult age enucleated, and there were some with long-standing and short-standing follow-up. So, as you would expect, the childhood patients, they have the largest difference. This is the bony orbital volume, so a reduction by 7%, less in the adults. But if you see, if you kind of correlate that difference to the age of the enucleation, there is no real correlation at all. But there is a correlation between the difference and the time interval between the enucleation. So the longer the time, the longer the follow-up. So patients 50 years enucleated, they have the largest differences. What does that mean? Enucleation, both in children and adults, result in a reduction of bony orbital volume, increasing with time. The reduction is more related to the time interval since enucleation than the age at enucleation. But the dimensions of orbital volume reduction are smaller than generally assumed. And for this example, that was a lady enucleated age 3, and here after her secondary implant, and there is no facial asymmetry, despite the fact that she was the lady with the largest difference of minus almost 15% in the bony orbital volume, but that does clinically cause no obvious facial asymmetry. So early enucleation does not cause facial malformation. And as a conclusion, there is no need for delay if there is early enucleation necessary, and no necessity to alert patients, parents, or pediatricians. This was what I put together for that topic of pediatric use dermal fat grafts. And shukran, and thank you very much again for inviting me.
Thank you very much, Dr. Hintschich. That was really very informative. I have a few questions for you, though. Of course, it was nice of you to answer this debatable question of should we wait for a young child 1 to 2, 3 years before enucleation and orbital reconstruction to avoid this facial asymmetry or not. You answered that very well indeed. However, there is no urgency to work on a patient who is below 2 years, don't you think?
Yeah, absolutely. It is not that we are doing that voluntarily, but there are sometimes there are tumors which have to be, eyes with tumors, they have to be removed, and we are talking of these patients. We are not performing nobody is performing voluntarily elective enucleations in small children. I absolutely agree.
Yeah. No, sometimes there's a child with a microphthalmic, a severely microphthalmic eye, or a post-traumatic atrophic eye. The parents are eager to do the operation at the age of 8 months or 1 year. Oh. So do you think we should wait or we should go ahead?
Absolutely wait. There is no need to enucleate actually there is never a reason to enucleate if there is not a real urgent reason. So if it is a very painful condition, if it is a microphthalmic eye which has a tremendously growing cyst, of course, and then I think I mentioned that even then there is primarily no need to enucleate that, but I would go forward in reducing that cystic part. So this is, and you never should have the patient's parents trying to put you under time pressure.
Yeah, great. Another thing is that do you think that this graft would work well in after post-radiation sockets? For example, if a retinoblastoma was treated with irradiation, do you think that there would be enough vascularity to harbor this dermal fat graft?
So this does finally very much depend on that socket. If you have a completely skeletonized socket where there is nothing, no tissue, no lively tissue, no soft tissue, then they do not work. But the majority, they are irradiated, but they do have soft tissue there, and then they do work. I had very, very few kind of failures, and one I remember that was in Amsterdam, when it was a completely kind of skeletonized socket. Then it's not worth trying it, but otherwise they work. And this is also shown in adults. Great. Often these are not children anymore; these are of young adults or adults.
I've got some few cases with orbital increase in size after the dermis fat graft with an abundant fat. I usually do debulking, but I find that they recur. I think it's like a natural tendency in these people. Have you had any experience with debulking and then the recurrence after debulking?
I think it is kind of it is connected to the whole body weight. This is something which we observed, you know, as in that young gentleman. If they are getting overweight, then the growth is kind of can continue. Otherwise, I do not remember that if there was if it's a young adult and where you reduce the size, I had no recurrence. I don't recall one, to be honest.
Okay. Dr. Samah, would you like to ask any question? Dr. Samah had his MD thesis in dermis fat grafting.
Oh.
Yes, I actually had my PhD in concentrated on dermis fat grafting, but recently I would like to, of course, ask Dr. Hintschich if about the place of harvesting the graft, because the harvesting it from the gluteal region had some troubles. It's a weight-bearing area. Patients have difficulties to sit, and so actually now I've shifted to the lower anterior abdominal wall, the groin area under the belt. It's more or less a hidden place, and also there is abundance of fat. I don't know what you think about this.
Honestly, we beside the scar, and this is something which might, of course, interfere with the aesthetical findings for young, particularly young girls. That is a problem. Yeah. I always tell it is a bikini, but the bikini is nowadays very, very small. Otherwise, we did not encounter complications. Whereas when I took sometimes at the beginning from the belly area, I realized that the dermis is much thicker and much better and heavier in the gluteal area. So I'm personally quite fond of that area because it is a relatively strong subepithelial plane which we are using there. So this is, but as we all know, there are many ways to Rome, and there is no study which proves that.
Yes. Okay.
Okay, any more questions, dear colleagues? We have quite one or two questions, few questions in the Q&A. Someone is asking, what is the minimum age for the dermis fat graft?
I do not think there is an absolutely minimum age. So our youngest, I looked it up, that was 8 months. Of course, we wouldn't do it in a 6 weeks old, but something like from 6 months onwards, you can use that. It is a bit, of course, it has not a 25 millimeters diameter then.
Yeah. Someone else is asking, what is your experience with injectable orbital expanders in cases of congenital and ophthalmic sockets? Do you prefer that than the dermis fat, or which is more preferable?
Honestly, I'm not very fond on these. I followed a number of studies from Paris and also from Rostock and Göttingen, and I personally am not using them. What I use, but not in children, in adults, I use autologous fat injections in anophthalmic sockets in the anterior part in the sulcus, and they do work quite nice and well. But otherwise, talking about kind of foreign material, whatever, they use glass beads which moved around. No, I have no personal experience, and I'm not. I will not use them.
Thank you very much. And now to move to my dear colleague, Professor Dr. Samah Hassan, who is going to give us a presentation about the difficult cases of Blepharophimosis syndrome.
Yes, is my screen seen by everyone?
No, Dr. Sam.
No, I can't see it yet.
Okay.
ساعد حضرتك في حاجة يا دكتور سامح؟
أنا عملت شير سكرين وبعدين بفتحها من كده. هل وضحت؟ أوكي.
مش ظاهر.
ديسكتوب. هل كده ظاهرة؟
لا.
أوكي.
تمام كده اوكي دكتور
Yeah,
سامح.
I think it's started to appear now.
Yeah.
Yeah.
presenter view. اوكي.
No.
تمام اتفضل يا دكتور سامح.
لا ثواني. هي لسه مش ظاهرة كده متهيألي ولا إيه؟
لا البرزنتيشن مش مفتوح، حضرتك افتح البرزنتيشن.
طيب أوكي. كده. هل كده ظاهرة؟
تمام يا دكتور سامح اتفضل.
Okay, so welcome everyone, and I'd like to, of course, to welcome again Dr. Hintschich and Dr. Hani Hamza, Dr. Arania. Thank you for this opportunity. Actually, my talk will be about blepharophimosis. Blepharophimosis has not been always the best case or the case that you're most happy to see in children. That's because the management of such a condition was more or less challenging and with a lot of complications. Let's start by defining blepharophimosis. Actually, blepharophimosis simply means a narrow horizontal palpebral fissure, but we usually refer to blepharophimosis syndrome as that syndrome composed of blepharophimosis, ptosis, and epicanthus inversus syndrome. Or another name, the Cohn-Romano syndrome, proposed by Cohn and Romano in 1971, when they published their proposal of naming this unnamed then syndrome. Blepharophimosis syndrome has two types. Type 1 is associated with primary ovarian insufficiency, while type 2 is limited to the eyelid manifestations only. These eyelid manifestations has four cardinal features, which is blepharophimosis, as we said, narrowing of the horizontal fissure, ptosis, which is usually severe ptosis with poor levator function. The third thing is epicanthus inversus, and the fourth criteria is telecanthus, or widening the space between the both medial canthi. There was another proposal for a type 3 blepharophimosis syndrome, adding the hypertelorism to these features, but this is not yet widespread and accepted. Also, the condition is associated with strabismus in 20% of cases, a variety of refractive errors, mainly myopia and astigmatism in 35% of cases, and amblyopia, which may be unilateral, bilateral or unilateral, and it's usually bilateral in 15 to 20% of cases. Genetically, there is a gene, only one gene known to cause blepharophimosis syndrome, which is the FOXL2 gene. It's related to the maldevelopment of a protein which is found in the eyelid muscles and the ovarian cells, and this explains the association with primary ovarian insufficiency. The transmission is thought to be autosomal dominant, and also the disease may be included, or blepharophimosis may be included in a variety of other syndromes. That's why pediatric consultation for these children is a must, because there might be another association or systemic problem that you have missed. And this is the value of gene mapping and counseling. Also, parent education in blepharophimosis is very essential, because a frequent question by the fathers is about their next child. Would he also have blepharophimosis or not? And of course, there is no clear answer to that question. But roughly, if you have one of the parents having the same syndrome and giving birth to a child with blepharophimosis, you have a 50% incidence of that the second child will also have it. Also, hormonal assay is very important, gynecological consultation to diagnose and manage primary ovarian insufficiency soon enough. But now let's get to our work, which is corrective surgery. Here we have the problems of blepharophimosis, essentially the medial canthal problem, mainly the telecanthus and the epicanthus inversus. The other problem is the ptosis. And as we said, most cases had severe ptosis with poor levator function. So most of the cases would benefit from frontalis suspension. And if there is a lateral canthus affection, mainly lateral ectropion, or if you need to widen the palpebral fissure at the lateral side, you might need to do a lateral canthoplasty. But regarding the ptosis and the lateral canthoplasty, there is no much controversy because the solution is clear. But regarding the medial canthal problem, the solution is not so, and you have many techniques to tackle this problem. And maybe this means that no one single technique is perfect. If you have so many solutions proposed for one problem, maybe we haven't found the perfect solution yet. So regarding the telecanthus, this is more or less easier and more straightforward, which is by doing medial canthal tendon resection or plication, fixing the medial canthal tendon to the periosteum at the level of the posterior lacrimal crest, or the more difficult and complicated transnasal wiring. And now let's get to the problem of the soft tissue excision and the epicanthus. Throughout the years, many techniques have been adopted, and all aiming at to achieve the best cosmesis and the least possible scarring after the technique. And here is what you need to get. We have the intercanthal distance in blue and the interpupillary distance in red. What you need to have after the surgery is that the intercanthal distance equals half of the interpupillary distance. And then you remove the excess soft tissue and mainly skin. Whatever the technique you use to remove this soft tissue, you are aiming at the best cosmesis and minimal scarring. Earlier, these pictures are like more than 15 or 17 years old. We used to do the Y2V standard technique, but it's still associated with scarring. But let me tell you that this technique is very useful in older children where the facial features have developed, and also in mild cases. It gives very good results. But actually in severe cases and in younger children, it's not, in my opinion, it's not the best technique to perform. Of course, the Mustard technique or the jumping man, it's named because it looks like a jumping man while fashioning the flaps. This technique helps a lot with large epicanthal folds, and especially also in young children. But as you see, it's associated with a lot of tissue dissection, a lot of flap transposition and preparation and trimming of these flaps, and surely a lot of sutures. And the scars are actually not very nice to have after this technique, but it can be done in younger children, at least, because they have a lot of time to heal these scars. But I think as the child age is more, also the scarring, you will not be very happy with the final scarring or the final result. This is another technique that I am using personally now, which is a C2U-plasty. Where you fashion two C-shaped lines or incisions. The innermost C-shaped line starts 2 to 3 millimeters from the lash line at the level of the lower punctum in the lower lid, and it goes to the upper punctum to a 0.3 millimeters lateral to the upper punctum. While the outer C incision connects these lines or these points to the point you already calculated that you need to excise the skin to get your results. And let me also give you a little tip to add like 20% or so of the amount of skin you need to remove to compensate for tissue healing. So this is the part you're going to remove, the part between the two C-shaped incisions. This is the part of the skin that you're going to remove to get the intercanthal distance equal half of the interpupillary distance. Of course, there are still scarring, but I think this scarring is much better than the 5 flaps technique. As you see, this is the final picture after like 2 months of surgery, and the scar is almost imperceptible. Maybe because it's very close to the ciliary line, or maybe because there are less dissection and less trimming of tissues, so you get less scarring. Another picture, this is a little girl we used to demonstrate the syndrome after surgery, and here we see, of course, a lot of sutures, and I recommend also using Prolene 6.0 sutures because the tissue reaction with Prolene is minimum, so you'll also, that would help you get a nicer scar. The lower picture is like 1 month after surgery, and I think these scars will still improve by time. Of course, there are many other techniques, the VW, the V2I, the double Z technique. As you see, we used most of the alphabets in these different techniques. Of course, there are a lot of studies, all, as we said, aiming at achieving the best cosmesis and the minimum scarring. And I think you just get to choose whatever technique that works best with you. Here comes the other question, is timing and sequence of surgery. Usually, it's recommended to do the canthoplasty first and then go ahead for the ptosis like few weeks or months after the first surgery. This allows, of course, the medial canthoplasty and the telecanthus repair, allowing fixation of the medial canthal tendon to the periosteum to get a good grip before attempting to correct the ptosis, or before attempting to exert another pull at this technique. And this is widely accepted as a proposed management or sequence of surgeries. But sometimes you need to perform the ptosis first. Like this child, he's very young and he had severe ptosis, and you have fear of bilateral amblyopia. So you need to do the ptosis first, and you still don't have ample tissues, or the facial features has not yet developed, so you can perform an adequate medial canthoplasty. But the drawback here is that by the time you are going to repair this epicanthus, you usually find yourself obliged to do another ptosis surgery. So this child may have to go into 3 surgeries to correct this syndrome. Another proposal by many authors is to do a simultaneous surgery, correct the medial canthal problems, and also do the ptosis. But the drawback here is that you're likely to be exerting 2 opposing forces, the one of the medial canthal tendon tucking and that of the ptosis, elevating the lid. So you won't get the much effect that you like for either. But actually, there are many studies that are published saying that they had comparable results using simultaneous surgery. So to conclude, the sequence of repair is controversial, but literature mainly supports a staged approach, the medial canthoplasty first and then the ptosis. The technique is up to you, whatever works best with you. I recommend the double C or C2U technique, but of course, again, it's up to you. And please, if you have a case with Blepharophimosis syndrome, don't forget any associated problems, especially primary ovarian insufficiency, and don't forget pediatric consultation for associated systemic syndromes. Thank you all, and let me remind you, this is a perfect time to have a cruise in Luxor and Aswan if you haven't tried it before. Thank you.
Thank you very much, Dr. Sameh, for this nice presentation. So I think now you made it clear that you prefer this C2U technique in nearly all your cases, except if it's a very young child, or if it was a teenager or something. What is the age that you don't do this technique in? What is the age that it's not preferable to do the C2Y?
No, I mean it's available. It's you can do it any age, but if the child is a bit older, like after 10 years or so, the Y2V plasty may work well. And also, if the epicanthus is small in mild cases, also the Y2V will work well. But I think the C2U plasty helps in younger children because of the time you have for the scars to heal.
Great. So, Dr. Hintschich, what is your current technique in correcting blepharophimosis?
Hello?
Yes.
I'm back. Yes. So I'm personally as what we were told, I'm very much against using the Mustardi because that really causes a lot of scarring. I personally do like and use in the absolute majority the V2Y. It is or the Y2V, whatever.
The Y2V, you mean?
Yes.
Yeah.
The results are very much depending on debulking the tissue, on removing the soft tissue which is in that medial canthal area. But what I do not do, and this is something which I'm quite surprised. I would not resect any skin because we know the skin in these children is relatively short to all sides. It is short to the lower, the anterior lamella, the upper eyelid. So we do a lot of fiddling and work to reduce the subcutaneous tissue, but we will not remove the skin. And regarding the age, of course, if there is a severe ptosis, we start with the simple brow suspension, and something like the epicanthal reduction or the Y2V is something we will usually wait until they are the age he mentioned, something like 10 or 12 or whatever. It's nothing I would do in a baby or in a small kid.
What about the lateral canthus? Because sometimes there is severe blepharophimosis that you, in order to have a successful frontalis sling, you need also to do something for the lateral canthus.
So are you asking me? So
yeah?
Don't touch the lateral canthus. If that's something causing trouble, it is if they are older, then maybe a young adult, but even then, it is nothing which gives any something like any positive sides to the result. I think you really should concentrate to the medial one, and to get a nice skin crease and the ptosis corrected.
Great. And Dr. Sameh, do you do anything for the lateral canthus in these cases?
Actually, as it was shown in the pictures, I did not touch the lateral canthus. I agree with Dr. Hintschich. Some people use it as an augmented procedure to help to give them a larger palpebral fissure, like performing lateral canthotomy and then switching the conjunctiva to the lid margins. But actually, I think if you do a good medial canthoplasty, it gives you the shape you want. You don't need to work on the medial and the lateral canthus at the same time.
Actually, I still work on the lateral canthus in severely narrow palpebral apertures, and I still do remove some pieces of skin because sometimes the skin is too redundant because there is an epicanthal fold. But I try to remove as little as I could. Okay, so
I think you sometimes you might need to remove a little bit. I called it trimming, just trimming. I don't cut skin, but sometimes coapting the flaps or coapting the skin. Find yourself needing to trim, not to have a dog ear or something, but
you
of course,
need to touch in a good incision. Yeah.
Yes.
Okay, so would you like to introduce the second presentation, Dr. Samer?
Yes, we have Dr. Yomna. Dr. Yomna is a fellow consultant oculoplastic surgeon with us in Cairo University Pediatric Hospital, and she will present, I think, two very interesting cases. Dr. Yomna, please share your screen.
Thank you, Dr. Samer. I'm sharing my screen. Okay, is it clear?
Yes.
Okay. Good evening.
We can see it.
Yes, thank you. Good evening, my dear professors and dear colleagues. I would like to welcome Dr. Christoph. It's our pleasure. It's my honor to present in such a knowledgeable meeting. My presentation is about a fulminant first presentation. It was a WhatsApp consultation from a dear colleague about a 2-month-old girl with periocular redness followed by rapidly progressive proptosis. The full-blown picture reached in few days, and she was only on topical treatment. Her CT scans showed extraconal and intraconal opacification, mainly involving the medial orbit, and sinuses were totally free. There was no history of trauma or fever or any systemic illness or any previous abnormal ocular symptoms. The differential diagnoses that came up in my mind at that time, whether it's a neoplastic lesion or an infection or a hematoma or acute hemorrhage in a hemorrhagic lesion or maybe other rare cause. So my recommendation was hospitalization, full ophthalmological assessment, full systemic examination, MRI with contrast, as it will show more details and it will help to get the biopsy when needed, and schedule for surgical intervention, whether to evacuate if it's an abscess or to take a biopsy if it's a mass, and meanwhile start broad spectrum parenteral antibiotics, not to waste time. 5 days later, my colleague sent me the MRI with contrast, and it shows the T1 and T2 enhanced cuts showed a cystic lesion involving the medial orbit, extraconal and extending intraconal with wall enhancement. Surprisingly, the impression of the radiologists came to suggesting that it is a venolymphatic malformation rather than an inflammatory lesion. However, this was not logic to me due to absence of the other characteristic signs of vascular lesions like fluid level. Ophthalmological assessment was normal, and it was done at a private hospital near their place as the mother was refusing admission, and parenteral broad spectrum antibiotics were prescribed by a pediatrician, and it was taken at home by her mother as she was a nurse, and they reported marked improvement of proptosis. Now the diagnosis is clear to me. It was a case of acute orbital abscess, but why there is no evident cause for this abscess, no sinusitis or trauma or any other ocular or systemic abnormality. I asked her for a recent photo, and this was her recent photo after the improvement of the condition. But what is this? Actually, this is a lacrimal swelling that has appeared, and she noted that it appeared just 2 days after she first texted me. I asked about watering or discharge, and the mother noted that there were minimal. Back to her imaging, it seems that I have missed this in her first CT. This is an extraorbital paranasal cystic well-defined lesion that is separate from the abscess with a fistulous connection inside the orbit, as shown by the red arrow. So this is a lacrimal sac abscess spreading into the orbit. Her latest image showed a marked regression of the abscess, and at last a precise radiologist put his hand on the definitive pathology, which was confined to the lacrimal sac and duct. We have to search for the lacrimal sac in our imaging not to miss such cases, and lacrimal sac in the CT is clear at the mid-axial cuts where the horizontal recti and the whole length of the optic nerve is evident and the crystalline length, while the nasolacrimal duct is evident at the lower axial cuts. Face-to-face meeting was scheduled, and dye disappearance test was done, and it proved the nasolacrimal duct obstruction. So I considered it as a lacrimal mucocele as we commonly face at our outpatient clinic, and I consulted her to do Krigler massaging, and forgetting that it's an infectious stage and the barriers are breached. And so 2 days later, the mother complained of periocular edema and redness. So I prescribed oral antibiotics again, and 2 days later, the condition improved totally. So this is evident. It's a case of a congenital nasolacrimal duct obstruction that was complicated by the most fulminant presentation, which is acute orbital abscess. But is this common? Actually, on reviewing the literature, the most common cause of orbital abscess in children is acute sinusitis. And most patients with dacryocystitis, which is still not common in the pediatric age group, develop pre-septal cellulitis or lacrimal abscess and not an orbital extension. And very few cases were reported in literature. This is due to the anatomical barriers, mainly the orbital septum, which actually was reported that it may be poor in infants, and the Horner muscle and the lacrimal fascia. Once the posterior barriers are breached, access to the intracorneal space may occur. On reviewing the literature, a report explained this fistula. It's due to the antero-inferior location of the sac to the globe, and a channel can form between the medial and the inferior recti to the intracorneal space when barriers are defective. And actually, this was very evident in the MRI of our patient. Reported cases in literature, as I mentioned, it's very rare. I have found a case reported in Iran, an infant of 5 months which developed dacryocystitis and associated with orbital abscess at the first presentation, and as shown in the CT scans and the MRI, as shown in her MRI scan. And she didn't respond to antibiotics, and they did surgical evacuation and probing. Another report was found. However, they were older patients, 50s and 30s, and actually they presented this condition turned into orbital abscess. On suspecting orbital abscess imaging selection, contrast enhanced CT has long been the imaging of choice, as it shows also the acute sinusitis and it shows the suspected orbital involvement. However, it carries a risk of radiation, especially for children, and it shows poor details in suspected neoplastic lesions. MRI shows more details. It shows the intracranial spread, and it carries no risk of radiation. The preferred modality is contrast-enhanced fat-suppressed T1. It will show the cyst of the sac and enhancement of the wall surrounding. Nowadays, the fusion-weighted imaging has come into the scope when when the contrast is contraindicated. On reviewing the literature for the proper management of orbital abscess, all orbital infections, all reports were mainly on orbital complications of sinusitis. However, it's the same orbital pathology despite the different source of infection. As according to Chandler classification, grade 1 preseptal cellulitis and grade 2 orbital cellulitis are mainly treated by medical treatment. plus or minus sure sinus drainage as recommended by the ENT consultants. And the subperiosteal abscess and the orbital abscess, this is the debatable region. For the management of the subperiosteal abscess and the orbital abscess prior to 1980s, before the evolution of antibiotics, surgical decompression was nearly universally recommended. However, nowadays it's very debatable whether to start early surgical evacuation of the abscess or to wait for the medical treatment to take place. However, it's being affected by many factors like the immunity of the patient, the orbital anatomy, the virulence of the organism. Put in mind on decision making whether to do surgical evacuation or medical treatment, it's very dependent on the age of the patient. Many reports suggested that younger patients have better prognosis, actually before 9 years old. The degree of proptosis, the size of the abscess, visual acuity and pupil condition, the vital signs, and all these examinations should be done every 4 hours. A major review on the management of the orbital abscess was published in an ENT journal. It was summarized, this algorithm was recommending or summarized that you can start medical treatment except if the presentation was initially aggressive, or if you tried medical treatment for 2 days and it shows no improvement, or if deterioration occurs in 1 day. Medical treatment in the form of intravenous antibiotics, nasal decongestant, and serial follow-up examinations and elevation of the head. At the end, what would have happened if it wasn't a WhatsApp consultation? Maybe I would have noticed the medical fullness from the start and confirmed the diagnosis. However, it seems in this condition specifically, it wouldn't have changed the prognosis a lot, as there was dramatic response to antibiotics. However, this is not always the rule, and close monitoring is a must in such conditions. And take-home message, an oculoplastic surgeon should be acquainted to basics of orbital radiology to get over orbital problems, and thank you.
Thank you, Dr. Yomna.
Thank you.
An excellent presentation, Dr. Yomna. Very interesting.
Thank you, Dr. Rani.
Actually, I was just wondering, would knowing the type of the organism help us to know the real site of infection? I mean, if we did a culture, could we differentiate between sinus infection as a primary nidus for the spread of the infection from the lacrimal sac infection?
I think if we have rushed to surgical evacuation, we may have cultured the contents we drained. I don't know exactly, the organism may be accused for in the acute acrocystitis in children, but I know for the sinuses it may be the Haemophilus influenza. I think this is the most common.
Yeah, I think pneumococci would be rather present in a case of lacrimal sac swelling, maybe. Maybe this would have made no difference because the antibiotics are wide spectrum anyway.
Yes. And I think that the radiology also confirmed the absence. It was totally free. It was totally clean sinuses.
Would you think that it might be initially orbital cellulitis and then spread to the lacrimal sac?
Actually, I thought of this because it was very strange, the appearance of the lacrimal sac swelling after the full-blown picture of the proptosis. I have thought of this, but when I did the nasolacrimal duct, the dye disappearance test, I was quite sure this is a nasolacrimal duct obstruction. So it seemed logic to me that the first was the obstruction and it was complicated by the abscess and not the reverse.
Dr. Hintschich, any comments? I think that the mic is muted. The microphone is muted,
sorry, now. Yes, I think this was really, Dr. Amro, very good presentation. And it pointed out actually two different aspects. First, this is a very rare reason for obviously for such an abscess. On the other side, the discussion how to treat a inflammatory lesion, which most probably is an abscess, there has been some debate, and you pointed out you start with that medical therapy, but you also pointed out if this is not improving within maximum of 1 day, I would say maximum of 1 day. I personally always would go for surgical relief. You know, we have that old word where pus that relieve it. So, but you pointed that out. So I think that made everything very clear.
Thank you.
Let me ask you about the crigler massage in general, and in this case in particular. Are you fond of this crigler massaging thing?
Are you talking with me?
Yeah.
This is it's a bit another topic. Nothing to do with that with that abscess.
Yeah, because I was just wondering whether it was a nice decision to do any massage.
Yeah, but I think this is a generally accepted rule, and I do not think you would really cause an abscess or a spreading infection by doing that. Otherwise, we would see that much more often.
Yeah. Let me show you, if I'm allowed to share my screen.
Actually, I think it helped.
Let me show you here. I have a case, an interesting case. Oops.
دكتورة رانيا حضرتك افتحي ايوه اوكي.
Okay. This one here. This is an interesting case that we encountered in the pediatric ophthalmology department. A patient who came with this fulminant cellulitis as well. It did not improve on antibiotics. Just to second your decision in starting to interfere after maximum 48 hours if no improvement. But this case was very interesting because we found this in her mouth. We found that there were some pus coming from one of her tooth beds. So she had a severe maxillary sinusitis with infection extending even through the palate. And she dramatically improved when we evacuated from this tooth bed using an endoscope through the maxillary sinus, and she improved and it healed fine. It was a nice case. I just wanted to show it to you.
Yes, that underlines, I think, the efficiency of surgical release of such an abscess.
Yes. Okay. Thank you, Dr. Yomna. Any questions from?
Thank you, Dr. Rania. Thank you.
Any questions for Dr. Yomna before she leaves us? Okay. So
I don't see any questions from the audience. So let's to Dr. Mustafa Noor, our fellow consultant oculoplastic surgeon in Cairo University Pediatric Hospital. Please share your screen, Dr. Mustafa.
Okay, hello, Sain.
Yes, yes.
Okay, can I start?
Yes, please.
Okay. Good afternoon, my dear professors and colleagues. It's my pleasure to introduce this small presentation about uncommon things do happen. I am Mustafa Noor, lecturer of ophthalmology, Cairo University. It's about a 12-year-old boy. He has moderate ptosis with poor levator function. He had history of exotropia and dead bilateral rectus recession with half tendon transposition 5 years ago. He had telecanthus that was treated by white OV surgery. Now this is a picture. He has moderate ptosis. So the decision was to do either a frontalis flap, fasciolata, or frontalis sling. We did him bilateral frontalis flap under general anesthesia. Pre-operative labs showed nothing about the bleeding profile. We did the usual frontalis flap surgery. However, we encountered this picture in the second post-operative day. The patient has a bilateral eyelid swelling, more common in the right eye. What is this surprise? We thought about lid abscess. However, the patient wasn't feverish and the swelling wasn't hot. Lid hematoma either due to local or systemic cause. So the decision was to do evacuation by opening the lid crease incision, trying to find any bleeder, search for systemic cause. We looked again to his labs. The INR was 1.4. It's a little high, but not so much. So we did the drainage. الصوت ده الاهلي جاب جون للاسف. It was done under general anesthesia. There was blood clot, but no pus. 2 days after evacuation, we are encountered by another bleeding, but it's more common now on the left eye. We had this severe eyelid hematoma more in the left eye. So why there is this recurrent bleeding? We decided to do CT orbit. We repeated the labs and asked more about the pre-operative history. We decided to do evacuation again, but with a placement of drain. Here, this is the CT orbit. You can see my cursor. There are blood clot here. It's more severe on the left eye. There is swelling in the right eye, but it's more severe in the left eye. Also, it shows here that it extends to the frontal area. We did the drainage under general anesthesia, scan crease in the right eye. We added subbrow incision in the left eye. We found blood clots and we placed the drains with loose suture. So now no more bleeding. We are trying to find what is the cause of this recurrent bleeding. 20 days after evacuation, he has the ptosis was improved, but he has still this little scar, and there is still browny edema found in both eyelids. This is pre and post-operative. What happened in this case? When we dig deeper in the history, we asked the mother specifically about any weight loss during the previous 2 months, or any change in the patient appetite, change in his labs, or did she perform any previous labs in the last 2 months. She reported that the patient lost weight over the last 2 months, and we found with her 2 contradictory results of C-reactive protein and ESR. The older one showed elevated C-reactive protein. When she repeated it 10 days before the surgery, it was negative. We looked about to his labs. We encountered that the platelets was about 200,000 and the white blood cells was more than 100,000. As the CBC was differential, it shows increased normoblast and increased immature cells. Unfortunately, diagnosis of chronic myeloid leukemia after consultation of our hematology colleagues, and the patient sent to the NCI to start chemotherapy. Chronic myeloid leukemia, it starts in certain blood-forming cells, the myeloid cells, that form RBCs, platelets, white BCs, except the lymphocytes. It's more common in adults. Since the introduction of tyrosine kinase inhibitor, it became a manageable disease. So what happened? In myelogenous leukemia, we may face increased incidence of infection, as we said in our differential diagnosis, lid abscess. However, the swelling wasn't hot. Number 2, the spontaneous or iatrogenic hemorrhage, which we may encounter in our case, a secondary neoplasm or granulocytic sarcoma, previously called coloroma. Back to our case. Is it a usual ptosis? If we see carefully, if we look carefully in the picture, we can see moderate ptosis. However, this ptosis was unusual. It started 8 months ago, and also we can see the lid crease in both eyes. However, the levator function was poor, as it was written in his data. What is granulocytic sarcoma? It said coloroma because it's a green in color. It has high amount of myeloperoxidase. It's more common with acute myeloid leukemia, not like our case. It can be diagnosed by MRI or by biopsy, and it may antedate the systemic manifestation of myeloid leukemia. by doing literature review, we are encountered by cases which were presented by unilateral ptosis. In cases with acute myeloid leukemia, there are 2 cases in the literature, one in Iran and one in India. Unilateral ptosis as initial manifestation of acute myeloid leukemia. So if I encounter this case again, I may go for a biopsy in the levator muscle or in the surrounding subcutaneous tissue, and I may do preoperative MRI. Take home message: uncommon things still have a place in our practice. We are treating patients, not eyes. It's not only about the INR in our preoperative lab. We should do CBC. In spite of being non-life-threatening specialty, we can have life-threatening patients. And thank you for the first case. If I have time to continue in the second case.
Thank you, Mustafa.
Thank you very much. Thank you very much. Really interesting.
It's very interesting.
Thank you, Dr. Mustafa, for this.
I can't hear you, Dr. Heba.
Interesting.
So this chap actually had 2 problems. First, I think he had some sort of.
I think we should take.
Sorry, Heba,
we should not take.
Heba?
Dr. Heba, your voice is.
Your voice is interrupted.
So superficially and so easy, and you cannot hear my voice.
Yes, but it's interrupted.
No.
You can close your camera. Try to close your camera and unmute.
Okay, I will be back and try again. Okay.
So actually, Mustafa, we have 2 problems in this patient. First is that the ptosis didn't seem a classical one. The infiltrated tissue seemed like rather a mechanical ptosis rather than a congenital ptosis, especially it's in that it didn't appear early in after birth. It just appeared 8 months ago, and the chap, I think, was about 8 years or 9 years old.
12 years.
Yeah, 12 years. The second thing is that what I wanted to comment on is that usually the chronic myeloid leukemia does not have platelet dysfunction, and we shouldn't have this severe hemorrhage after surgery. So this is actually not only a weird presentation, but also a weird behavior of the chronic myeloid leukemia. Usually the platelet function is affected in the acute leukemia.
Yes, yes, but still they may have some sort of bleeding, non-intact bleeding profile in the platelets. It's more common in the acute myeloid leukemia. However, chronic myeloid leukemia may have this presentation. And also, as I said, it has a bilateral ptosis, and it's not written in the literature about the infiltrative process to affect both leads simultaneously or in the same time.
Yeah, this is very unique in everything. Thank you for giving this opportunity for us to see that case. Thank you.
Thank you.
Heba, you're back with us now?
I'm back again. Can you hear my voice now?
Yes.
Yes, it's clear.
Okay. Good evening,
Yes.
Dr. Rania. Good evening, Professor Hintschich, and good evening, all the speakers, and to all the attendees. On behalf of the Memorial Institute Kids Eye Center team and the whole Mayor, I'd like to thank you all for this invitation to this very valuable collaboration with Abulreesh team. As every pediatric ophthalmology hospital, the pediatric oculoplasty is very important part of the hospital, and so I'd like to start and thank the Mike Oculoplasty team, and I'd like to start and present Dr. Ahmed Abulfatouh, our oculoplasty surgeon and pioneer. Dr. Ahmed Abulreesh, you can start sharing your screen. The screen is yours and the platform is yours.
Thank you, Dr. Aheba. I'd like to thank all moderators for this great opportunity. My presentation will be about case presentation. I would like to present two pediatric post-traumatic cases. I'll try to illustrate how I think and how to manage these cases. I will highlight some tips and tricks in the surgical management, and I will touch lightly about the systemic workup of trauma cases. The first case, female child, 13 years old, presented with ptosis in the right upper lip. The ptosis is moderate to severe with the fair levator function. The crease is muffled. She is myopic with good pills, intact corneal sensation. She is orthotropic on examination. The condition started after a successful squint surgery. She have intermittent XT and do bilateral lateral rectus recession 7 months ago. Soon after recovery from anesthesia, she have a blunt trauma by her hand to her right eye. So we think about what happened. This is a traumatic ptosis. Is it iatrogenic? Superior rectus advancement is a common procedure that results in iatrogenic traumatic ptosis, and we work about lateral rectus muscle, so it is excluded. We can exclude also myotoxicity from anesthesia, as it is reversible in most cases. Traumatic or mechanical ptosis, the post-operative picture and after trauma, there is a big hematoma, but it resolves in few days. Leave only a subconjunctival hemorrhage and a teeny granuloma in the upper lateral quadrant of the subconjunctival region. So the mechanical ptosis is also can be excluded. Is it neurogenic? Generally, neurogenic starts as a complete ptosis and almost always associated with other nerve palsy, which is not the case. Traumatic myogenic ptosis also happened in sharp or violated injuries with sharp objects, and also can be excluded. Due to the large hematoma and the appearance, we can suggest that is a traumatic abneurotic ptosis or mixed mechanism. We take a detailed history and examine everything in the eye, anterior segment and periphery of the fundus was free. So we decided to correct this traumatic ptosis. We consent the patient and their parents for surgical correction and exploration of levator muscle and the removal of the subconjunctival granuloma. The consent is important in these cases as we face traumatic cases. The incidence of secondary surgery is high, and second, go to operative theater for repair of under or over correction of ptosis is common in these cases. First, we explore the granuloma by incision in the conjunctiva, removing, isolating the lateral rectus muscle by hook, and granuloma excised under vision. By reviewing the literature, there is many papers and researches that gives tips and tricks in surgical management of traumatic dose. Now we pay attention for exploration of levator muscle. We take the anterior approach, which is recommended in these cases by transcutaneous approach. And we found that the septum is not violated, it is intact. We open the septum and start to disinsert the molar levator complex from the anterior surface of the tarsus. We started the section, but we found that the molar, this is the molar muscle, and the wide gap of conjunctiva is bare. The levator stump is not present. In these cases, we always look at the important structure, transverse ligament or Whitney ligament, and we search about it. We know that we can find the lost stump near to the aponeurosis. We are lucky to find the stump. We grasp it with the forceps and assess is it a stump or not. Take a suture for it for fixation and assess the relation between the stump and the pre-aponeurotic fat. And due to the large distance between the tarsus and the lost aponeurotic muscle, I decided to not to resect any part of the levator, and for fear of unexpected results. So I decided to refixate the levator muscle to the anterior surface of the tarsus. I using 600 Becquerel suture with partial thickness suture to the anterior surface of the tarsus, 1.5 millimeter inferior to the upper border of the tarsus. I enforce this suture with another lateral suture, and I start to close the skin, entangling the muscle with the suture to form a new crease. This is a photo post-operatively. This is taken 1 week after surgery. There is mild edema. There is a little bit under correction. If I face a case like this in the future, I would like to go towards the overcorrection a little bit, because overcorrection is much more easier to correct than undercorrection. This is a photo of pre-operative and post-operative. This was the first case. The second case, male child, 4.5 years old, presented with recurrent right medial cancer mass. This mass is previously diagnosed as chalazion, and he do surgery for excision of the chalazion, and after that recurrent inflammation, and the mass recur again with severe contraction of overlying skin. The presentation is unusual. The parents deny any history of trauma, recent trauma. They have no histopathology for the excised mass that is diagnosed as chalazion. The surgery done 1 month ago. On examination, there is severe medial side upper lid retraction. There is a palpable mass, and there is a punctate epithelial erosion signs of corneal exposure. I asked for a photo while he is sleeping. The parent sent this photo. The problem is over with poor Bell's phenomena. Lubricants are described, and I order a CT orbit. CT reveal heterogeneous mass in the upper nasal superior quadrant of the orbit, not eroding the bone and not compressing the bone. Again, we consent for exploration and the mass excision and the biopsy. I do an anterior approach, a skin crease incision, or the anterior orbital approach. The fibrosed skin is totally excised, and the septum is found open, and we found this thing, a foreign body. We extract 3 pieces of wood and some little pieces around. We wash and try to evacuate this area from the granulation tissue around the foreign body, and try to clear the area. We send the granulation tissue for histopathology and the culture and sensitivity, and start some antibiotics, and do because of the large defect of the skin, we do skin graft post-auricularly in another session when the condition starts to calm down, and we revise the history of the parent again. They told us that before the first operation of excision of the mass, by 2 months, the child fall on a wood table. It was a mild trauma. They give him an oral antibiotics and anti-inflammatory, and the trauma is passed unnoticed. Then the mass appeared, and the story starts. This photo is post-operatively after the skin graft suture removal, and this is his photo while closing his eye. Now he followed up by about 1 year. There is some irregularity in the contour of the upper lid, and we follow up him for fear of lack of thalamus again. He may need in the future another graft or so. Take-home message: don't underestimate minor or neglected trauma. Histopathology and imaging is an important tool in cases of atypical presentation. In any trauma case, meticulous history taking is crucial. Thorough examination is mandatory. Investigation is a valuable tool, but exploration may complete the puzzle. Thank you.
Thanks, Dr. Ahmed, for this very nice 2 cases. My impression is that the history taking and the thorough and the good history taking in oculoplasty practice is a main core. One of the main core
your voice is interrupted again, Dr.
reaching the diagnosis. I noticed
Your voice is interrupted, Dr. Heba.
We can't hear you. Yahya.
Good. The oculoplastic. Okay.
Dr. Heba, your voice is interrupted. Can you get out and come in again once more?
Now, can you hear me, Dr. Rania?
It's better now.
Okay, I was just saying that my impression is a good history taking in oculoplastic practice is a main core in reaching diagnosis of cases. And my second impression is, as for me as a pediatric strabismologist, I can't go alone without pediatric oculoplasty in the house. My impression from the first case, strabismus case, and the best thing is to be like Dr. Rania, strabismologist and oculoplasty surgeon. Thanks, Dr. Ahmed, for this very nice two cases. And now, any of the speakers...
Can I just comment on your presentation, dear Dr. Ahmed, please?
Yes.
I mean, even if we took a meticulous history, still, I don't think that the trauma that both children or both cases suffered explain what you found. Because in the first case, she was hit by her own hand. I mean, this is really strange to have such a minor trauma, and then you get elevator aponeurotic disinsertion or something like that. And also in the second case, he was just hit by the table. Even the table was not reported to be broken.
No,
so this is really strange. I mean, this is not. I mean, this.
Unusual behavior of the trauma.
Actually, Dr. Ahmed, these little pieces of food we have seen it before.
Not just. Yeah.
Did you think about being self-inflicted?
I don't think they are looks stable, and and the finding is explored intraoperatively.
Okay.
We didn't have
one thing I'd like to ask you about the repair of the elevator aponeurosis. You mentioned that you use Vicryl 6.0. Do you think Vicryl is stable and long enough to give you a long-lasting result? Don't you prefer Prolene, or what do you prefer for repairing the elevator aponeurosis?
Usually, I use with elevator resection Vicryl 6.0 or 5.0 Vicryl. I don't use non-absorbable suture.
Okay.
Professor Hintschich, what's your opinion in these cases?
Yes, for the first case, the history with that kind of minor stone fist, I think that's difficult to understand. She had surgery before. Couldn't that be that there was some surgical reason for that? Just as a question. For the surgery itself, for the corrective surgery, I did not get. Did you do it under local or under general anesthesia?
General. She is 12 years old.
She was 12 years old. Yeah, but then it's difficult and it's brave, because we all know it is so much easier and better and safer to do that under local, because then if you have to distinguish the structures, it is easier to find. So that was quite congratulations to find that retracted levator and to refix it. That for sure. And with the second, of course, I think everybody who is dealing for many years in that field will have one or two or three examples of neglected orbital traumatic foreign bodies, which often are wood, and they are difficult to distinguish because they change also their behavior in the imaging with time. So this is a very classical finding, and quite good for educative purposes. Thank you.
And because it is wood, it is an organic and causing very aggressive reaction around.
Yes, absolutely.
Well, if you allow me to talk, this case was my case. The case was just waking up from the anesthesia, and it was not a trivial trauma. It was a strong trauma from her hand to her upper lid while waking up, and it was not a trivial trauma. I think a strong trauma can cause this dehiscence. What do you think, Dr. Rania?
I think that we have to exclude some sort of domestic fights that was not reported in both.
Thanks, Dr. Ahmed, for the nice presentation. And now let's present. Let me present to all of you Dr. Iman Nasr. She is a pediatric oculoplastic consultant in the Mayor, Mike, and Godi, and she will present to us a presentation about the facial asymmetry cases in oculoplasty. Dr. Iman, the screen is yours.
Bismillah ar-Rahman ar-Rahim. Can you hear me?
Yes, Dr. Iman.
Yes, Dr. Iman.
Good evening, everybody. And I wanted to welcome Dr. Hintschich, whose face is symmetrical. Presented by Iman Sultan, oculoplasty consultant, and assisted by Rihan Fathi, oculoplasty fellow, whose face is symmetrical. None other than George Clooney. Symmetry is a complete match in size, location, shape, and arrangement of each facial component about the sagittal plane. Types of asymmetry might be vertical, horizontal, or mixture. Analysis of facial symmetry is an important component of attractiveness. The non-symmetry seems to be more important than that of the lips. Both soft tissue and hard tissue are important to assess and gain facial symmetry. Symmetrical faces are considered highly attractive as asymmetrical, but completely symmetric faces are not perceived as normal. Bella Hadid is most beautiful woman in the world, but Leonardo DiCaprio, Beyonce are very attractive. Let's discuss facial asymmetry in children. This might be congenital, environmental, functional, and always have various patterns depending on the personal characters, onset of time, muscular compensation, musculoskeletal development of the face. Scientists have discovered that at age 83, people typically have more symmetrical faces, reflect better socioeconomic circumstances, while those with less facial symmetry may be related to higher levels of stress, infections, toxins, or even genetic differences. The preference for symmetry was stronger for males and female faces, adults than children's faces, while the influence of symmetry on attractiveness judgments emerges after the age of 5 years and matures after the age of 9 years. Newborns always have facial asymmetry due to the softness of the skull bones, the pressures in the uterus, the regular placement of the infant in one position during sleep. But there are many serious conditions that can be considered and simple conditions that should be differentiated. Let's start by serious conditions. Torticollis, which means twisted neck. There are two types, non-ocular and ocular. The non-ocular is due to the affected sternomastoid muscle with unclear cause, most probably due to sudden changes in calcium level. It resolves with continued graft. It might remain even, may result in plagiocephaly, which is a flat head syndrome. The ocular torticollis appears with trochlear or congenital superior oblique palsy, where the child intorts his eye to balance out the extortion of the eye. He does head tilt to the opposite side. There is association of midfacial hemihypoplasia on the opposite side of the paralyzed or affected muscle, with deviation of the nose and mouth toward the hypoplastic side, as we can see here. There are other causes of ocular torticollis, like nystagmus and corrected astigmatism, sixth nerve palsy, Duane syndrome. That's why thorough examination is mandatory for every kid. Number 2 is microsomia, which occurs during fetal development due to the affection of pharyngeal arches. Usually have ear abnormalities, absent ear canal leading to hearing loss. Other abnormalities may affect the spine, the kidneys, and the heart. Eye problems are less common in such cases. Microsomia has different names. The most common for us is golden heart syndrome. Number 3 is congenital facial nerve palsy. As we all know, there is lack of sinus and exposure of the cornea. That's why the treatment will be considered to protect the eye and to recreate the smile. This should be differentiated from Mobius syndrome, which is the affection of 6th and 7th cranial nerves. There are also other cranial nerves affection. That's why it is recommended that every child presented with facial palsy to be examined for other cranial nerves and to check the mouth and the tongue, especially to check the deviation due to the affection of hypoglossal nerve. Now, for the ficomatosis, we have different entities like sturge vapor with port wine appearance, and neurofibromatosis with cafe au lait patches, which should be differentiated from the Albright syndrome. Albright syndrome is one of fibrous dysplasia, which is due to gene mutation. It is a chronic problem in which scar-like tissue grows in place of normal bone. There are 2 types of fibrous dysplasia, the monostotic and the polystotic. The monostotic is due to affection of only one bone, as we can see here. But the polystotic is affection of multiple bones in addition to the other systems of the body, especially the endocrine system, and there is also cafe au lait patches. Now, number 7, something called progressive facial atrophy or Perry-Romberg syndrome, which is a slowly progressive deterioration of the skin, soft tissues on one side of the face. The cause is not well understood. It is often associated with a type of linear scleroderma called encoupe de sabre. Encoupe de sabre means in English, sword cut. So as we can see here, an infant 2 years old with a little bit symmetrical faces. At 5 years, asymmetry started to appear. And at 11 years, there is hemifacial atrophy associated with coupe de sabre. As we can see here, the characteristic coupe de sabre with the atrophy. Now, craniostenosis, which is due to the premature fuses of sutures. There are different types depending on which suture will close prematurely. For example, the trigonocephaly due to the premature closure of the metopic suture leading to hypothyroidism. The brachycephaly due to closure of both the coronal sutures leading to Crouzin or seen in Crouzin syndrome. Also the pansynostosis due to premature closure of all sutures, and we can see with Apert syndrome. Now, don't forget the microphthalmia, nanophthalmia, and enophthalmus and anophthalmus. They will also lead to asymmetry of the face. The post-trauma, post-inoculation, post-radiation, and post-medication. This child came to the clinic seen by Dr. Reham and was diagnosed and guided by Dr. Asymmetry. And in adults, both Botox and post fillers. Now, the simple condition that should be differentiated from serious one. Something called congenital asymmetric crying, where the infant's cry was crooked due to hypoplasia of the depressor anguli of this muscle. So the lower lip asymmetry is evident only during crying. There are two types, the killer syndrome and the catch-22, a acronym for cardiac defects, abnormal facies, thymic hypoplasia, cleft palate, hypocalcemia, and a variable deletion of chromosome 22. So, killer syndrome must be suspected if a baby has a symmetrical cry pattern with normal faces during baby sleeps. As we can see here, completely normal, but affected left or affected lower lip. If there is other associations, so it will be catch-22. To sum up, facial asymmetry is a big deal, as many celebrities like Stallone, who has facial nerve palsy since birth, Faiza Kamal with killer syndrome, Adam Pearson with neurofibromatosis despite having a normal identical twin brother, Nell. But the very important and the most serious is to diagnose and differentiate between the serious conditions and the simple one. So, my advice to proceed through right diagnosis, through good management, and by the way, management is an Arabic word, means munaja. It means that I need to have good diagnosis and treatment, and diagnose it through taking a good history and making a good science and examination. So morphometry and the holistic facial asymmetry score, which is done by Ulm University, Baden-Württemberg, Germany. Thank you so much, Dr. Rania, for this webinar. I also wanted to extend a special thanks to Professor Dr. Asymmetry. He has been and always a great help and support. Last but not least, for my colleagues in MI.
Thank you very much, Dr. Iman, for this comprehensive summary. And thank you for all those George Clooney's pictures. We really enjoyed it. Thank you.
Thank you.
So any questions to Dr. Iman, or we proceed with the next final presentation? We have a question in the Q&A. There is a question, which medication causes facial asymmetry? Any medication that causes facial asymmetry, Dr. Iman?
Yes, this child was taking something we don't really understood, but Dr. Assam suggested that it is for hair graft, and it might be with castor oil or something like prostaglandins. We are not quite sure.
Yeah. So off we go with our final presentation by my dear colleague, Dr. Karim Bakr from Cairo University, who is going to talk about the ptosis surgery revision. Dr. Karim has done a lot of ptosis surgery at Abulreesh Pediatric Hospital, and I'm sure he will give us a very good presentation of all the possible causes of revision. Thank you, Dr. Karim.
Thank you, Dr. Rania. Thank you, Dr. Lemah, for this kind invitation. My talk will be about ptosis surgery revision, how to prevent and how to manage. As we know, ptosis is abnormal dropping of the upper eyelid to lies below the normal anatomical position. We have different types of surgery: myectomy, levator cutting resection, witness suspension, frontal flap, and frontal sling. Our aim to have a noise level with a good contour, with a good symmetry from the first intervention. Either by conjunctival, right conjunctival, left elevator tucking, sorry. Left elevator tucking.
Dr. Karim, your voice is a little bit muffled. Can you improve the voice, please?
Can you hear me now?
Yes, I think this is better. Yeah.
Okay. The first patient was right conjunctival, second patient was left elevator tucking, third one was left.
No, once more it's muffled. Once more it's muffled.
was third elevator section, sorry. First two patients with frontalis flap in the right eye, the third one with right frontalis sling. But unfortunately, it's not always the case. Sometimes we need to re-interfere. Indication for second surgery in ptosis is either due to undercorrection or overcorrection. They are the major indications. Contour abnormalities, intropion or ectropion, colorectal collapse. In some studies, it's high as 20%. Undercorrection is common in patients with severe ptosis with poor effector function. May be due to poor preoperative assessment, inadequate measurement of the levator, inadequate measurement of the levator function, without bracing of the frontalis muscle or pulsar action of the frontalis muscle, or in we did detect mastocytosis. Also, surgical surgery. Sometimes we choose the both surgery. Surgical technique, inadequate cutting or resection, incomplete cutting of the tight horn of footna ligament.
كريم ممكن نعلي الصوت شوية، نعلي صوتنا شوية.
اوكي حاضر اوكي. بس هو Post operative, we have loosening the suture. The suture was so superficial in the tarsus, or the bite was so superficial, or the abnormality was attenuated. In case of severe edema or hematoma, prevention to start with careful measurement of the amount of tooth and levator function, and detection of mastocytosis, preoperative planning and proper choice of the surgery, intraoperative lid adjustment. We may face different charges during tooth surgery as the amount of anesthesia infiltrated. If we inject a larger amount, it may cause severe edema and undercorrection. The use of epinephrine to control hemostasis sometimes stimulate the molar muscle and cause overcorrection. Pre-existing lack of sinus, it may affect our intraoperative lid adjustment, amount of post-operative swelling and hemorrhage. Management, we observe the reduction of the edema and hematoma for about 3 months. Then do incision surgery, whether the same surgery or a different surgery, frontalis fasciolatus sling in the first 2 cases and frontalis flap in the third case. Overcorrection is common in patients with good levator function. Prevention by accurate measurement and proper intraoperative adjustment. Management start with observation, lubricant for the exposure keratopathy, downward traction and massage. It may help. If everything fails, we can go for vision surgery with recession. This patient with left ptosis underwent surgery with left picking and or medial picking and overcorrection and improved with massage. Contour deformities, we have different types of contour deformities like picking of the upper lip, nasal central or temporal, lip sagging. This patient had a left lateral sagging or flat eyelid contour. Causes of contour deformities may be due to flat contour in case of the suture is far away from each other, or eyelid picking the suture too close to each other. Also, the length of the suture in the tarsus may affect the contour. If we took a long tarsal bite in the long suture bite in the tarsus, it may lead to flat contour, while a short bite may lead to breaking of the eyelid. Management will start by opening the wound and suture replacement, and you can take more additional suture. Asymmetry of eyelid, crease, or skin fold is the second most common complication of ptosis surgery after overcorrection and undercorrection. Creation of eyelid crease is a crucial step in ptosis surgery. How can we prevent this complication? By proper marking the skin incision according to the other eye. Placing the suture to attach the levator to the edge of the skin is very important, and sometimes we need to remove a small amount of skin to avoid the skin fold. Sometimes we have a low crease. This patient with the left eye ptosis, we do a ptosis surgery which is fine regarding the contour, but has a lower left crease in the left eye compared to the normal right eye. While the second patient he has ptosis in the right eye, underwent levator resection. He has overcorrection, lateral picking. It will improve, but the will not improve the right eye crease. To manage the low crease, we can do a higher crease here and undermine the scale and the in between and suture the crease in the higher position. While in the low crease, we can inject fillers above the crease to rest it down or start to make a new crease underneath this one and opening of the septum to raise the fat and act as a barrier to prevent readhesion of the skin to the previous crease or previous higher crease. Introducing made of care, it gets shortening the posterior lamella in relation to the anterior lamella. This patient with right eye ptosis, contour is fine, level is fine, but there's some mild introduction with slash ptosis. The tarsus is divided into three thirds. We should take suture at the junction between middle and the upper third of the tarsus. If we take the suture too high, it may lead to introduction. If we take the suture too low, it may lead to extrusion. Introduction lead to cosmetic disfigurement, rubbing eyelashes, and may end in corneal ulceration. Okay, it's mild to wait for observation, aiming for continuous resolution with severe vocal anterior mirror reconstruction. Ectopia with excessive anterior and superior ball of the eyelid margin. This patient with right eyelid ptosis, we do a frontalis flap surgery for him. Everything is fine, contour is fine, level is a little bit fine, mild overcorrected, but there is a mild ectopia in the right eye. Okay. So this is the elevator suture to inferior the tarsus, or the sling is attached too far inferior to the tarsus or to squartation. Management is by adjusting the elevator of the sling attachment. We need skin graft or flap if this skin is removed in the breast surgery, or any tightening of the eyelid in case of lax upper eye. For example, blacks is common in traumatic ptosis, and in cases of enlarged elevator resection. Okay, due to intertransversal ligament of severe fornix and may be aggravated by excessive edema and hematoma. Management starts with observation, repositioning, post thickness, 3 horizontal massive suture for the conjunctiva to the skin, or by excision. Simulation may occur in a posterior approach and may cause introduction. Management is either by rush scar release or by putting graft or a mid graft to cover the area to prevent readhesion. Thank you.
Thank you very much, Dr. Karim. I think you gave us another comprehensive lecture on the ways to correct ptosis and the management of the complications. I have got one question for you here. One of the doctors in the audience is asking you, how do you scale for the amount of levator resection needed to correct the ptosis? What is your preferred technique for that?
Okay. This part is under local anesthesia or under general anesthesia. And under local anesthesia, I prefer to do surgery under local anesthesia to adjust the level while the patient is sitting during the surgery. Okay. Under general anesthesia, there is many techniques. My technique, I depend on the intraoperative palpebral pressure height. I am aiming to a palpebral pressure height equal to amount of ptosis plus 3. Okay. I add 1 millimeter for every 3 millimeter lag of Thomas. So if I had a patient with MRD2, so I want the palpebral pressure height to be 6. Amount of ptosis is 3 plus 3 is 6. Okay. This is the aim at the end of the surgery. If I have lag of Thomas about 3, I add 1 millimeter. The surgery factor difference between different surgeons. So you should start your surgery and do your algorithm. I talk about the levator tucking or levator resection surgery. Regarding the frontalis flap of ptosis sling, I am aiming to have the eyelid at the level of the superior limbus.
At the level of the superior limbus, right?
Yes. Yes.
Okay. Okay. Dr. Hintschich, are you still with us?
Yeah, but I have to admit it was extremely difficult for me to follow.
Yeah, I was just asking, what is your preferred technique for scaling for the amount of levator resection you would do for a certain amount of ptosis?
Honestly, I do not measure at all. I never measure the length or the amount of tissue I will either forward or then finally resect. So I do judge as my colleague Dr. Karim mentioned in the local anesthesia in those patients, it is for me also the best to have them in the upright position and then to judge. And there is not so much I would add or I would reject. Of course, we all know if there is the poor levator function, then we try to get it finally as high as we can, because then we have to deal with the problem of lack of Thalamus. Of course, it's difficult or dangerous if there is no bell. Otherwise, usually it works well. It is more difficult, as we all know, in the sleeping, in the kids. And again, I judge it kind of guided by experience, by the height I get on the table. Somehow getting up to the limbus is actually, I rarely get that as an aim. First, it is difficult. Secondly, I think it is a good tendency of overcorrection if it is, again, not a very poor levator function. But this is what every, I think, ptosis surgeon does more or less the same. But I'm not measuring. That was the question.
Okay. Another question is that how do you answer the parents or the patient if they tell you many friends and acquaintances have told me that probably the ptosis will recur and I will probably need a second surgery?
What do you're still talking with me? Yes, it is probably. I wouldn't say it probably. There is a chance. The lower the levator function is, the higher I think the risk is for a recurrence. Of course, you might tell it, but it is by far not the rule to get a recurrence. And yes, this is the only thing I can tell him. But they wouldn't have a choice actually. Either they leave it as it is, or they take the risk of the recurrence.
Sure. And what's the preferred age for your interference for a congenital ptosis, sir?
This very much depends on the findings, and I'm not. I do rather operate early, and the guidance for this is that if you have the pupillary axis not only covered, but it is partly covered. There are studies that you cause refractive errors. There is a study on the Blepharophimosis syndrome that came from London. There are some animal studies, all this with the chicken. Again, it's not the rule that you get refractive errors is if the pupillary axis is rather low. But if there is any, of course, any tilt of the head, if there is any risk for amblyopia, I do operate early, whatever, between six months onwards.
And if there is nothing and the pupil is not covered?
Beg your pardon,
if there is no problem and the pupil is not covered and no risk for amblyopia? Oh
yes, then I discuss it with the parents, but I wouldn't do that before they go something like aiming for school 5-6 years or so.
Great. Dr. Abul Futuh, and what is the preferred age for your interference for congenital ptosis with no interference of the pupil and vision?
If there is a pupil cover, as soon as possible. If there is head posture or a refractive error difference between the ptotic eye and the normal eye, I will interfere. And otherwise in the preschool age.
Okay, and of course the famous question in cases of unilateral congenital ptosis with poor levator function, what is your preferred technique, Dr. Sameh?
Actually, I know there's a lot of debate about whether you have to, if you're planning to do sling surgery, only. I find it very difficult to convince the parents doing it by doing bilateral surgery for a completely healthy eyelid. So I always prefer to do single eye surgery. Sling surgery, frontalis suspension, using preferably fascia lata suspension, only on the affected eye.
Okay, and Professor Dr. Hintschich?
Yes, this is absolutely the classical question. There have been debates for decades, and there have been books on that. Yes, it is. I would agree on not touching both eyelids if it's not necessary. I go down below the 4 millimeters if I decide whether to do a direct anti-elevator resection approach or a sling. I always tell the patient this: we could do the sling later if it's necessary. And I'm not anymore afraid of a unilateral sling, since I've seen quite reasonable good results. However, this is something where I tell the patient there is no perfect way actually to repair if there is a big difference, a unilateral ptosis on the long run.
Yes.
Excuse me, can I share my experience regarding unilateral ptosis?
Sure, Dr. Iman, please.
Thank you. So I will share a case. This child came to me. He is 1 year old with unilateral ptosis, and unfortunately, I decided to go through maximum resection without doing sling. And on table, after finishing the procedure, and on the other day on follow-up, I found that as I entered, I gained the same result with the same ptosis, and there is no more function. And I really apologized to the parents, and I told them that it was my mistake, as I assumed that the muscle might work. And we decided to re-enter that child after 1 month to not be exposed for general anesthesia another time. And after 1 month, I went and I decided to go through a sling, doing Gore-Tex sling. And the parents was really very happy. And even before the surgery, they asked me, are you confident that this time there will be no recurrence? Really, I was afraid, and I was a little bit hesitant to do the surgery. And I even advised, if you wanted to go to do in your country, is it okay for me? I can't judge what will happen, but after Gore-Tex, they were really, really happy, and even they sent me a gift. And after this case, I do really recommend doing unilateral sling, and don't expect that any dystrophic muscle can't work, especially with the unilateral ptosis, and in infants that we can judge well the levator function. Thank you.
Thank you, Dr. Iman. Well, I think Dr. Heba will conclude our meeting today. Before leaving her to conclude that, I would like to thank everyone once more, and special thanks for our great guest of honor, Professor Hintschich. I'm sorry we took so much time from your schedule today, but it was really worth it to have you with us, and we thank you very much for coming today.
Thank you very much for inviting me, and it was a great pleasure. Actually, I learned a lot. Particularly all these patients with asymmetric faces, patients I never even heard about the disease. So that was absolutely great. But I have to emphasize, I hope this will not be the standard for the rest of my academic life. So I hope to be able to travel again for a proper meeting.
Yes, sure. We would like to welcome you here soon.
Yes, both ways. So thank you very much.
Thank you.
Me too. I'd like to thank Professor Dr. Hintschich for his very nice presentations, comments, and sharing in this highly knowledgeable meeting that is not happening every day. Those cases and these topics are not discussed frequently in the meeting, and so we were very excited to for this meeting, and I enjoyed, though I'm a pediatric ophthalmology, strabismus and cataract consultant, I enjoyed all the talks. Actually, pediatric oculoplasty is a very, very highly specialized subspecialty in the pediatric ophthalmology. I respect this specialty too much because you are not only preserving and keeping the function in collaboration with all the other subspecialties in ophthalmology, keeping the function of the eye, but you add to the quality of life of many kids, many people, and teaching and learning pediatric oculoplasty is really a very, very add to the humanity. Thanks for all the speakers, thanks for all the attendees, for keeping you late and preventing you from watching the Zamalek and Ahli football match. And thanks Dr. Rania, Dr. Hani for the invitation, and thanks to all the speakers. Thank you.
Thank you all.
Good.